Okay. I'd like to present Associate Professor Bert Boffa. He's kindly agreed to present some recent case studies on silicosis. So I'll hand you over to Bert.
Thank you very much. Good evening. Welcome to our autumn meeting of Science series. I'd like to, in support of our speaker, share some recent cases I saw in my IME practice. The first such case seen August last year. A relatively young man, actually, a full-time sandblaster, with his employer from 95 to 2000. Now, of course, quartz was banned in 2002, so he's had the full gamut of exposure to quartz sandblasting material in his career. So he sandblasted all sorts of metal fittings, trucks, trailers prior to painting. He had an air-supplied helmet, but no overalls, and so would have been exposed to dust in his skin and so forth. On his history, there was no extraction in the workplace, and he advised that the floor and surfaces were covered with what he termed sand, and I think in those days it was sand. So it's clearly no high efficiency ventilation that we're required to have these days. He reported developing pharyngeal and sinus catarrh, persistent dry cough and shortness of breath in 2008. It progressed and he developed shortness of breath on minimal exertion. CT showed bilateral apical scarring and mediastinal node calcification consistent with sarcoidosis and silicosis. Chest X-ray was similar. Pulmonary function tests showed a moderate obstructive pattern, no bronchodilator response, and impaired diffusing capacity. The worker was diagnosed with chronic simple silicosis with sarcoidosis, and he attended pulmonary rehabilitation without much benefit, he tells me. He continues with once daily bronchodilator and anticholinergic preparations. He's prescribed regular courses of antibiotics for episodes of increased breathlessness and cough as presumed episodes of infection, and he sees his GP regularly for ongoing surveillance. He reported daily dry cough, breathlessness, sharp pleuritic chest pain, and regular bouts of increased breathlessness and cough. Mildly strenuous activities such as domestic chores would exacerbate his breathlessness. Walking was limited to 200 metres. His cough was worse at night and he slept sitting up virtually. He last worked in 2013 when suitable duties were withdrawn. No obvious respiratory history. Was an ex-smoker at the time before he started working as a sandblaster, had no particular sports or hobbies at the time. Look, he had normal speech cadence, skin colour, no obvious signs on examination, midline trachea, symmetrical chest movements, no osteotrophic signs. He had reduced chest expansion and his forced end expiratory time was over 4 seconds. So that's that gentleman. A similar picture also seen in August last year. On this occasion was a 73-year-old full-time miner and mobile plant operator with his injury employer some 15 to 20 years. He mined quartz and high-grade silica dust filled the air during the crushing operation. And again, he described covered surfaces, thickly covered with dust. He wore a air purifying respirator for most of his career and an air supplied helmet just in the last 12 months of his career. He had developed shortness of breath, dry cough in 1990, retiring 7 years later. Interestingly, he developed psoriasis for the first time at body sites where he said dust had collected in his clothing. He also developed mediastinal lymphoma in 2007. Respiratory function tests in 1990-97 showed moderate restrictive lung disease, had progressive chest X-ray changes during surveillance. He was diagnosed with silicosis and also lymphoma on biopsy in 2007. Now, when I saw him, had severe widespread psoriasis, which we'll discuss later on. It may have been a trauma, injury, irritation phenomenon rather than a direct complication of silicosis, but we can discuss that later. He uses regular inhalers, and he had chemotherapy for lymphoma and remains in remission. He has ultraviolet treatments and creams for his psoriasis. He controls shortness of breath and dry cough by remaining calm and not rushing. He has a carer who helps with domestic chores and shopping, and he no longer does any gardening, lifting or carrying. Walking slowly is restricted to 30 minutes, and he continues to lose weight. Had no previous psoriasis or respiratory problems, never smoked. Apart from psoriasis, again, he was not breathless at rest or while talking, reduced chest expansion, and again, forced end respiratory time was prolonged. So they're my two case studies to help hopefully inform the discussion tonight. Thank you. I don't know if there are any questions on the details of these cases, but here we are. Thank you.
So with the first case, so
yes.
I just query about the diagnosis. So of the sarcoidosis and silicosis. So did he have a biopsy that proved the sarcoidosis? Because obviously radiologically it can be very difficult to differentiate the two.
Yes. Now I can't from top of my head answer the question, but you would imagine you're correct that there would be a mediastinoscopy performed with biopsy. I imagine that would be the basis of diagnosis, wouldn't it?
Yeah, so we actually very rarely do mediastinoscopy these days. So we do a procedure called an EBUS. So it's a bronchoscopy with an ultrasound probe at the end, and so we can biopsy the mediastinal and hilar lymph nodes very effectively, very low risk in doing it that way, and we get very good diagnostic samples. So EBUS really is the preferred method rather than mediastinoscopy these days. Mm-hmm. But yeah, I do wonder, especially, I think you mentioned it was chronic simple silicosis, whereas, I'd be questioning whether you might actually have progressive massive fibrosis rather than simple silicosis.
I guess it was termed simple, chronic simple because of the long time frame, I think, rather than a very, I understand accelerated means accelerated in progress.
So with chronic silicosis, you can have chronic simple silicosis or chronic complicated silicosis. So the chronic complicated silicosis is the same essentially as progressive massive fibrosis. So the chronic aspect is obviously based on the latency of disease, that it's been diagnosed after 10 years of exposure. So but the simple aspect more is a reflection of the size of the nodules.
Yes.
So if they're less than 10 millimetres in size, then it would be simple silicosis, whereas if they're bigger or they're starting to coalesce, then that's more complicated or PMF.
Well, the ILO reports I saw termed in chronic simple silicosis. And in sarcoidosis, I'm not sure if there's a biopsy. One would imagine what it was in the biopsy. Is psoriasis a known complication of silicosis?
Not that I'm aware of, no.
There we are. So this must be something we can write up.
If it is in fact caused by silicosis.
There we are. Thanks very much.
Thanks very much, Bert. Next, I'd like to introduce Dr. Ryan Hoy, who's very kindly agreed to present tonight. Just a little bit about Ryan. I'm sure a lot of you probably know Ryan, but he's a respiratory physician. He has a master's degree in occupational and environmental health. He's actively involved in research and teaching in the field of occupational causes of lung disease as Senior Research Fellow at the Monash University School of Public Health. And he's in clinical practice at Cabrini Medical Centre in Melbourne and also at the Alfred Hospital. So I'd like you to please warmly welcome Ryan. It'll be, his presentation will be on, on silicosis and in the 21st century. Thanks, Ryan.
Thanks, Robin. And thanks for the opportunity to come and talk tonight. So I'd like to apologise at the outset in case some of you have seen some of my slides already. I have talked about this at a couple of other meetings over the last 6 months or so. So I'm really going to focus on really what is a major problem that we're dealing with at the moment in Australia, certainly in Queensland, very much emerging very rapidly in Victoria at the moment. But this is actually a problem internationally, so not just an Australian issue, which I'll talk about. And so it's the re-emergence of silica as an occupational dust exposure and the health consequences and complications from this exposure. But silica exposure is certainly something that has been forgotten about over time, especially in the construction manufacturing industry. A lot of people talk about silica as being the new asbestos. I've heard that sort of thrown around recently, but really silica and the risks related to silica certainly predate our knowledge about asbestos. So asbestos was actually the new silica, but really got forgotten about in terms of a significant cause of lung disease and other health problems. So silica exposure doesn't just occur in the mining sector. So we expect that workers will come into contact with silica when it's in its natural environment, which is inside the ground, so in the Earth's crust. So obviously if you're a quarry worker, you may be exposed to silica. If you're a miner, you may be exposed to silica. But silica is also used in a lot of other industries too. So this is pretty recent data from a group in Western Australia, and they undertook a cross-sectional survey of Australian working people, so between 18 and 65 years of age. And they noted in their survey that 6.4% of respondents were exposed to silica dust in their work and 3.3% at a high level. And the highest prevalence of exposure was actually in the construction industry. So not in the mining sector or quarry work, it was actually in the construction industry. And so you can see a picture here of pretty typical work that's done on a lot of building sites. And so where I'm based at Cabrini, they're putting in a new 7-storey building at the moment. And every day I see out the front there concrete cutters that are lining up to do repair work. And I don't think doing this sort of work at the hospital. So these are some of the what we think of as non-traditional industries where silica may be encountered. So agriculture. So I heard of a case of silicosis from a horse racing track that was sand-based. And so as the horses gallop around and around and around, just pulverizes the silica with the sand towards a respirable size of silica. Certainly ceramics, so pottery workers, workers with tiles, very well described, for well over a couple of 100 years. As I mentioned, construction industry, definitely concrete cutting. It's actually really hard to find out how much silica is in concrete. It's really very varied. So it varies between 10 to 70% silica. So same thing with bricks. So the silica content of bricks really does vary quite a lot depending on how they're actually manufactured, but probably around about 50% silica. certainly highway repair, bitumen, even dental materials, some contain silica. Definitely abrasive blasting. So many people will know of the terrible outbreak of silicosis in Turkey related to workers that were sandblasting denim jeans to give the jeans a really distressed look, so that aged or worn in look. And so they had a really large outbreak of silicosis in Turkey as a result of that. But also cooking pan manufacturing, jewellery workers, the new practice currently of natural gas fracking. They often use sand as a propellant in that industry. And then bringing us on to stone benchtop fabrication, which is really what I want to spend most of my time talking about. So this product we refer to as artificial stone. It's also referred to as engineered stone or agglomerated stone or quartz conglomerates. Also reconstituted stone. A lot of the workers in the industry just call it recon. That's what they typically refer to it as. There's lots of companies that actually produce this material. None of these companies are in Australia, so it's all produced overseas. Caesar stone has the market share in Australia, so 52% of the market in Australia is Caesar stones at the moment. Caesar stone's based in Israel. They've got a manufacturing plant in the United States as well. And then we import the slabs of stone from those companies overseas. So Essa stone, Sila stone, Smart stone. There's some that will actually come in directly from India and China as well that don't have these sorts of trade names with them. So initially developed in the late 1980s in Israel and then really came into use in Australia in the early 2000s and really just took off by about 2005 to 2010. So really exploded in popularity over that time. So when you talk to workers in this industry, there's a group that worked with natural stones for many years. So they might have started in the industry in the 1980s or so. We're very used to working with marble and granite. And then by this time in the mid-2000s, really just shifted what they were using. So they shifted to artificial stone. And because it is quite cheap in comparison to the natural stones, it became extremely popular and there lots and lots of new businesses were set up around that time. So a lot of people entered the workforce in that late 2000 period that weren't stonemasons previously. So it really took off about that time. You can get all sorts of colours. It's non-porous, it's scratch and stain resistant, and it's much more impact resistant than granite. So it's certainly got a lot of features that make it ideal for kitchen bench tops, bathroom bench tops. Often it's in laundries. We were just questioning before whether the bench top actually out there is probably an artificial stone. So really, if you look around, you tend to sort of just see it everywhere. And as I say, it's really taken off. So this is data from the Caesar Stone company overview. And so their revenues increased from about $200 million in 2010 up to over $500 million in 2016. And so interesting to look at the market share in Australia. So this is the Quartz market share. So they call it quartz, but essentially this is artificial stone. So Australia is quite an early adopter of it. So in 2010, 32% of all bench tops were made from artificial stone. And so that increased to 45% by 2016. So really significant increase. And so that's 45% of all new bench tops going in are made from artificial stone. So it's a really big industry. Israel, which is, say, the home of Caesar stone, has got a huge proportion. And then Canada and the US less than us, but certainly based on, especially in the US, the size of the population there, the number of workers that are exposed is also very high. So one of the reasons why it's really taken off in Australia is one is the need or the desire to have the greatest and latest kitchen, and the trend really has been for these stone bench tops. The renovations, the shows like The Block and various other renovation shows that really promote having your kitchen updated very regularly. but also the increase in apartments that have been put up. This is actually on the Gold Coast. But, we have the same issues in Melbourne, as we know, with the huge expanse of the number of apartments, especially around Docklands and other parts of the city. And also housing estates. So in these housing estates, one of the things that they usually promote is that they've got stone bench tops, Caesar stone bench tops is one of the things they really promote quite heavily. So what is artificial stone? So essentially, this is a material that's produced from finely crushed rock. So they get rock from the local quarry, which is actually next to the Caesar stone manufacturing plant. And then it's finely crushed, and then it's mixed with some resin. It's mixed with some other additives, mixed with a pigment as well, depending on what color you want. And then it goes through this vibrocompaction process. So, and then it goes through a heat curing process to form that final slab. And then there's some polishing afterwards. Caesar stone don't release the number of cases of silicosis they've actually had at the manufacturing plant, but I've got it on good authority that they've actually had quite a few. So the main issue with this material is the high silica content. And so as I said, people in this industry used to use a lot of marble, which only has 2% silica in it, so not much at all, and granite, which is about 30% silica. And artificial stone has well over 90% silica, so it's an extraordinarily high amount of silica that it does contain. And then, as I said, it's got some resins and some other additives in it as well. So it's got the same amount of silica, essentially, that sandstone has. So you can imagine if you work with sandstone, you're probably pretty aware of the potential risk of silica exposure, whereas in this industry, it's been very poorly recognised. And certainly talking to a lot of people that even trained as apprentices, went through TAFE colleges here in Melbourne, they were never educated about the risk of silica exposure in their industry, which I find to be, completely unacceptable. So these are what the slabs initially look like. So they're imported looking like this. And then the workers and the benchtop fabricators then need to modify them to the client specifications. So that means cutting that big slab down to size. Usually they use a big CNC type saw to do that. It really varies a lot depending on the setup of the workplace as to sort of practices that they have. Some have large water jet cutting machines. Some just uses, say, big CNC saws with a bit of water suppression. But what we are most concerned about is when this work's done with hand tools. And so often workers will use these high-powered hand tools to make the cutout. So they cut out where the sink goes, they cut out where the tapware goes. And they're very high-intensity tools. And what's been very commonplace in this industry is the lack of any water dust suppression. So as you can see here, this plume of dust that's generated as that cutting's done. So they do cutting, and they often use grinders as well to cut out that area, and also to mitre the edge of the stone slab, and then for the fixation of it as well. So there's actually been really very little research that's been done into the amount of silica that's generated from these work activities. So this is one published paper, and so this was published in 2015. And so they looked at varying control measures using this device here. And so what they found was that with dry cutting, so if they use no water, if they use no local exhaust ventilation, the levels of silica that have been generated over a 30-minute work period was 44 milligrams per cubic metre, which is an extraordinarily high amount of silica. So if there's no regulated standard for a 30-minute exposure limit for silica, but the recommendation is that it shouldn't exceed 0.3 milligrams over that work period, and should never exceed 0.5, whereas these levels are obviously a huge amount higher than that. And then if you extrapolate that over an 8-hour work period, you're looking at a level of about 1,700 times what the TWA is. And there's certainly a move now in Victoria to reduce that level down to half what it is. So, you know, it's far, far above what the exposure standard is. I think a reflection of the issues in terms of enforcement of regulations. Yes, Bruce.
Standard, the Australian standard or American standard or what?
So the 8-hour TWA for silica, this is Australian, so it's 0.1. So
exposure?
Well, there is no regulated. So I think there's recommendations as to what it shouldn't exceed, but there's not actually regulated levels.
Within Australia, there's recommendations.
Well, international recommendations that it should never exceed 5 times what the TWA is, and at any particular time. But I think that's a really important point because, you know, in this industry, it is more about short-term, high-intensity exposure, and I think it's something that's really been overlooked in terms of the regulations. So, but what's also of note here is that even with wet cutting, so when they were using water to suppress dust, the levels still were very, very much higher than what we would consider to be a safe level. So using water alone is not actually a control measure that can be thought of as being definitely safe. And that's a bit of a problem currently in terms of the advice that these workplaces have been given by the inspectors. So a lot of inspectors are going out and saying, well, you can't dry cut, but wet cutting is okay. But that's definitely not been proven that that's actually the case. So, you know, so we do have significant concerns about the sort of advice that's been given to these workplaces. So really the only way to know for sure is to actually have independent dust monitoring done, so personal monitoring as well as some static monitoring, really independently done, which has been very much not the routine in this industry. So it's interesting though to compare the amount of silica also to our knowledge about coal mining. We've got a lot of knowledge about pneumoconiosis from the coal mine sector, including silicosis. And so this is looking at the percentage of silica in coal mine dust. And we know it's the silica content of coal mine dust which makes that particular coal mine dust more fibrogenic to the lungs. So depends on the geography of the or the geology of the coal mine as to what level of silica is actually in the dust. And so this is data from the US that shows the mean percentage of silica in the dust is about 6% in surface mining, about 5% in underground mining. And obviously in that industry, there's high levels of regulation, there's high requirements for health surveillance. You know, if you enter a new mine site, you need to have had an X-ray done beforehand. There's a lot of boxes you need to tick. Whereas in this industry, this is a report from the CDC in 2015. And so they looked at the percentage of silica in dust that was generated through this work activity. And so when grinding was performed, the mean percentage of crystalline silica in that dust was 62%. So in comparison to say the 5% in the mining sector, and the maximum was actually 92% silica in that dust. So, you know, extraordinarily high amounts of silica. So, and so that's really what we're concerned about. This is a very different type of exposure to those workers in the mining sector. So very different to what we think about as chronic silicosis. These workers are exposed to probably intermittent periods of very high intensity exposure. So if you're going out on site and you're doing installation work, you might be doing small cuts to actually modify the size of the bench top so it can actually fit in appropriately if the measurements haven't been done properly. So that periods of high intensity exposure very much differs to that chronic low or moderate exposure. There's not a lot of data about this, but there is some that show that short-term high intensity exposure has 3 times the effect of lower level exposure over the longer term. And that as you're cutting that stone, the freshly generated particles have more reactive free radical species on their surface, which actually is much more fibrogenic as well. So there's a lot more we need to know about in terms of this type of exposure and the effect on the lungs. So this is a patient of mine who told his story on the 7:30 report last year, and this is pretty commonplace, the level of silica dust exposure that these workers have. So, they say that during their work shift, when they're doing dry cutting, they get air hoses out and just have to spray off the amount of dust that's on them. They get into their car at the end of the day, just covered in dust, and then they get back in their car on the weekend. They turn the air conditioning on, just like all this dust comes out of the vents because it just accumulates in their cars. They walk through the house, and there's just like footprints of dust as they go through the house. So it's really extremely high levels. So this is actually a disease that's been reported in this industry overseas since 2010. In Italy was the first report, and then more and more reports in Europe. 2011 in Spain, another group in Spain in 2013, and then more reports after that. But really, the group in Israel have reported their experience from 2012. So this paper was initially published under the title of Caesar stone silicosis, but they had to rapidly change the name of the paper to artificial stone silicosis at the request of the company. I'm not sure if it was a request, I think it was more a demand, but so this is from the lung transplantation service in Israel, and they identified 25 workers, 25 patients that were referred for transplantation due to silicosis over a 14-year period. And by 2014, they had about 200 cases that identified without really being proactive about it. So they really haven't been proactive in terms of screening the workforce in Israel. There's a lot of, I think, probably political reasons for that in Israel, but they really highlighted in their paper back in 2012, 7 years ago now, that this was a really important outbreak and that it really needs to be recognised for that, and that more cases are likely to occur unless effective preventative measures are undertaken, which obviously did not happen. So this is the first case in Australia. So this was reported from one of my colleagues in New South Wales, so Deborah Yates. And so this is a worker from Sydney who's got a Vietnamese background and presented with worsening shortness of breath, and has now undergone lung transplantation. So he this case was published in 2015. And through the Thoracic Society, obviously we were very concerned about this, and we put in our group, we got together and we started to advocate to various government agencies in 2016 about this problem. And we put together all the cases that we had seen in our practices. So this is just a pretty basic case series. And we pretty quickly found 7 patients in our practices. These are from Queensland, Victoria, and New South Wales. And although it's a really small retrospective case series, it was quite, I think, quite insightful into some of the issues in this industry. So some really young people, so 2 that were 26 years of age at presentation, and all had worked in the industry for a relatively short period of time prior to the onset of symptoms, so between 4 years and 10 years. So, really very short periods of time for silicosis. So, when we think about chronic silicosis, it's usually 20 years or 30 years. So, this is, far, far shorter. Health surveillance wasn't done at any of the workplaces, even though it's a regulated requirement. There was dry cutting done in all the workplaces, very small workplaces usually, so between 3 and one had up to 20 workers. Yeah, many were born overseas, so we've seen quite a few workers, especially in Victoria, from Vietnam, that came to Australia as refugees and, were very well when they entered Australia, and then have worked in these workplaces and have developed very severe silicosis from it. And so again, there's a lot of limitations with the data we had from the retrospective series, but we did go back and look at their lung function over time, and they had varied patterns. Some were obstructive, some were restricted, some had mixed patterns. Most had impaired gas transfer, we found the really significant and rapid loss of lung function over time, so about 10 times greater than we would expect for normal age-related decline, so really rapid lung function decline, even having left the industry. So this is ongoing decline with no further exposure. And similarly, we found radiologically there was pretty rapid progression too. So from some areas of ground glass infiltrate, possibly a few nodules at baseline, and then you start to see a few more nodules, but still quite atypical features for silicosis. So normally we think about just discrete nodules, but we're seeing more a ground glass type infiltrate, which is not the typical pattern. And then those nodules coalesce and then developing pretty classic features of complicated silicosis or progressive massive fibrosis. So, over 36 months to have gone from a relatively normal CT to quite marked silicosis. So we've now transplanted 3 people with silicosis at the Alfred. One, unfortunately, has now died. One we transplanted towards the end of last year. And this is just an idea as to what their CT looked like, one of them looked like before transplant was performed. And you can see just the extensive loss of lung tissue as a result of the replacement through the silicosis process. And you can get emphysema as well related to it. As you can see, there's bullous emphysema up the top here, a bit of emphysema down the bottom as well. And so because they had undergone transplant, we actually had their explanted lung to look at. And so what we found was that it's quite a unique process, what we've seen so far, that a lot of the lung tissue is replaced by silicotic nodules, which we know about with chronic silicosis, but a lot of intervening fibrosis that you can see around here. So loss of the normal lung parenchyma. And in the areas where you could actually see the alveolar spaces, there was also this intraalveolar proteinaceous material. And so this is quite typical of what we refer to as acute silicosis or silicoproteiноsis. So really we're seeing a bit of a mixture between chronic silicosis and acute silicosis. So quite a different pattern to what we've seen previously. So there has been quite a bit of media attention about this over the last few years. So there was a story in The Age back in 2017, and it's been very, you could get me talking about this all day, but it's been very disheartening, to be honest, how slow it's been to actually have some response from, the regulated agencies, Safe Work Australia and all the agencies around the country. Despite, clearly having a lot of very sick workers as a result of this disease. And so this is Anthony White, who told his story on the the Sunday Project last year and died just a few weeks ago because of his silicosis. And so he was on the Gold Coast. And so because the reason why there has been a lot of data, a lot of activity about this in Queensland is not because it's any different in Queensland, it's just that they were a bit more aware of issues related to occupational lung disease. Our group at Monash was involved in the review of the coal workers health screening program. And we found a lot of deficiencies with the screening program, and it was quite a big political issue in Queensland. So back in about 2016, 2017. So when this problem came along, they actually were very proactive about it because, they realised that they really needed to be on the front foot. And so they implemented a screening program just in last September. So it feels like it's quite a long time ago, but it was actually only last September that there was an initial audit of 10 businesses and screening of employees, and they identified 36 with silicosis, so 1/3 of the workforce, and half of those had evidence of progressive massive fibrosis. And so in February this year, so they've now identified, it's actually about 110 cases that have identified in Queensland so far. It's a bit unclear as to how many have actually gone through the screening program in Queensland. But talking to Graham Edwards in Queensland, it sounds like it's probably around about 400 to 450 workers that have completed that screening. So about 100 of those have evidence of silicosis. So quarter of the workforce. So there's a lot we don't know so far or at the moment about that, which we're hoping to improve our knowledge about very quickly. One of the issues is what tools to use with screening, and I know a few of you in this room have been involved in these discussions. We have traditionally used the chest X-ray, so the ILO reported chest X-ray. This is from our comfort with it in the setting of chronic silicosis in the mining sector. And the early issues related to this are that it's actually not picking up a lot of cases. So this is some very, very, very preliminary data from Queensland that was reported last year. And they noted that 16 out of 31 workers that had a normal chest X-ray actually had evidence of silicosis based on an HRCT. So as a screening tool, it's very unclear as to whether a chest X-ray that's ILO reported is actually sufficient. So really, when we're thinking about screening now, we have a very low threshold for recommending a CT is done as part of that screening, but that really needs to come back to the exposure history. So thinking about the intensity of exposure and the duration of exposure that individual worker has had, and that should form your basis as to whether you do a CT scan or a chest X-ray. And so that is a decision for the occupational physicians that are doing this screening. So there may be consultation with a respiratory physician as part of that. When a person gets to somebody like me as a respiratory physician, they will have all hopefully had a HRCT done, or if they haven't, will do a CT. So, as a diagnostic assessment, I would never rely just on the chest X-ray. So, meaning if you're concerned at all, you should probably just get a CT done. So, because really they're going to get one done anyway. So this is a job history questionnaire that we've developed at Monash that is hopefully going to be a major part of our screening program here in Victoria, which I'm not allowed to say too much about, but will hopefully be rolled out very quickly. So, but what we've really thought of in terms of our focus for this questionnaire is really that these are people working with extremely high silica content material. We don't know how effective any of the control measures are, in particular the masks and ventilation. So really what we want to know is the size of the industry, so how many other stonemasons are working in the area. We want to confirm that they actually do use mostly artificial stone, that it's more than 50% artificial stone, which in this industry is pretty much everybody. We want to know a little bit about what jobs do they do. To me, this is actually, I think this is important, but it doesn't help us a huge amount in terms of really looking at finer detail of their exposure. What we really want to know here is whether you're involved in on-site installation work or if you're actually in a factory. So those are the two main differentiating things we want to know about here. And then what amount of time you've actually spent in an environment where there's dry processing going on. Because again, like I showed you before, if there's any dry processing going on, the levels are hundreds of times higher than what the exposure standard is. So what proportion of time have you been in an environment where there's dry work? And that may not be you, it might be the worker next to you that's been doing dry work. And then we've just got a pretty standard job history, because the difficulty with this industry is that most of these workers have been in often to 3, 4 or 5 different companies over time. So we do need to know a bit about their exposure history at previous workplaces as well. And then so from that, we can then look at some stratification of their level of exposure, which can then look at things like whether they should have a CT done or a chest X-ray would be sufficient. And over time, we'll then be able to look at our other data that we're going to record as well, looking at disease progression and various other things as well. But so, so if you really, we've got a very low threshold for saying that somebody has very high silica exposures. So if you work with over 50% artificial stone, and if you spend greater than 10% of your time in an environment where there's dry processing, you're going to have very high silica exposure. So the other ones are high. Still, this level is above what we consider to be safe, but it compares to very high versus high. But what we need to do also is think about other tests we don't do as standard tests for silica exposure. So really important to assess gas transfer, not just spirometry. And we need this done at the moment to be done at a Thoracic Society accredited laboratory. Even our laboratory at Cabrini is not a Thoracic Society accredited laboratory. If you go to the TSANZ website, there's a list of accredited labs. And, we're being very strict about this at the moment. So if it's not been done there, it really needs to be done again. And so we know quite a lot of people have gone through some ad hoc screening. So some people have been sent to their GPs and been told to have screening tests done, which is not sufficient and probably has to be repeated afterwards. There's a lot of other silica-related conditions, especially autoimmune disease, connective tissue disease. It probably affects about a third of people with silicosis. So especially lupus, scleroderma, rheumatoid arthritis. So these really need to be thought about. I've got probably about a third of my patients do have associated autoimmune disease. So the size of the workforce in Victoria, it's been estimated between about 1,500 and 2,000 workers in Victoria. So we've actually got a bigger workforce than Queensland. Queensland's about 800. Work practices in Victoria are probably actually worse than Queensland. So, at the moment, really, we need to know how many people are affected by this and for them to all go through a high-level screening program so that they're really properly assessed. So this is just a bit of a summary of what I've said, but I'm happy to take any questions or discussion points. Andre's got a hand up.
Yeah. Ryan, can you make some comment, please, about HRCT and the role? Because one of the cases that I've seen not that long ago was recommended to have HRCT. He went to his GP because with the work cover system in Victoria, if they've had screening, we don't have anywhere else we can directly necessarily refer them to. They have to go via their GP, then get referred on to a respiratory physician. And his GP sent him for a contrast CT scan, which was not helpful, just came back reporting TB because he had old TB scars. And the other thing I've heard as well is that the B reader for the chest x-rays is recommending that the HRCT be read by a B reader, which I sort of think is appropriate. Yeah,
so I think that's a really good point. So the HRCT needs to be a non-contrast CT. The reason why a contrast CT is a problem is that you then get contrast in the blood vessels, and so then it's very hard to actually differentiate that from silicotic nodules. So it really needs to be a non-contrast CT. So again, if somebody's actually had a contrast CT, we'll often actually end up repeating it and doing a non-contrast CT. But yeah, in terms of the radiologists, that is an issue. So, and this was certainly a big problem when we started seeing a lot of these patients 2 or 3 years ago, that a lot of it was actually misdiagnosed as sarcoidosis because the radiologists weren't thinking about silicosis, and the radiological pattern is not typical of what we previously saw with chronic silicosis. So, upper lobe nodularity, increased lymph node size, young person, the radiologists are going to think of sarcoid. So, most of you know what a B reader is, but we've got in Victoria, we've got one accredited B reader that's gone through the proper NIOSH program. So he works with IMED. So it's really, I know it's very, we don't want to sort of, say one company is better than another, but, IMED's got the only qualified B reader. So if you get a chest X-ray that's reported from, another radiology firm, which I won't say the name of, it may not be actually reported by B readers. So if you've got a query about it, you need to contact the company and actually ask them, is their radiologist actually a B reader qualified radiologist? So, you definitely need to actually ask that question. But yeah, so it's important then that the CT is reported by somebody that's got expertise in occupational lung disease, which is why it's better that the same B reader looks at the X-ray and then looks at the CT scan so they can actually make a comparison.
If I can ask a question, I mean, how much do you need to pursue the diagnosis of sarcoidosis in a CT that shows pulmonary architecture distortion and fibrosis and nodules and eggshell calcification? Should it just be routine, even though the exposure history is highly suggestive of high risk of silicosis?
So we're at the moment, we're working through a clinical pathway for these cases. So early on, my practice was to actually biopsy pretty much everybody, and they would have an EBUS. Sometimes we did what's called a cryoprobe biopsy, where you actually freeze the lung tissue and you pull out a little plug of it. We were doing some surgical biopsies. At this point, my practice has changed quite a lot because I've seen so many that, I'm pretty comfortable making the diagnosis based on radiological grounds and exposure history. But it may change. So, because what we don't want to miss is something that's more treatable, and sarcoidosis is certainly more treatable than silicosis is. So, it really needs to be decided on a case-by-case basis based on clinical grounds, and that's something I always tell the respiratory physicians. I think some of them think, oh, well, I need a tissue diagnosis for a work cover claim, but I've said that's definitely not the case, and really should be done only for clinical purposes. But just to complicate things further, there is actually an association between sarcoid and silica exposure as well. So you can actually make a good case that sarcoidosis is caused by silica independent of silicosis. So, but
I mean, one of the...
sorry, is there another one online there? Yeah.
I'll come back a bit. Look, I might just continue with an observation. I mean, one of the issues around silica and mining and the ILO classification is that, in a sense, it's based around this model of low cumulative exposure and perhaps the 1% likelihood that simple silicosis will arise from decades of exposure. This goes completely the other way. And in that kind of model of sort of silicosis, you had the opportunity for early detection. And in fact, even if it missed the first chest X-ray and you caught it on the second chest X-ray, you were often at the stage of simple silicosis. This doesn't seem to have quite that ready progression for radiology to, at least the plain X-ray, to pick up something that is in an early stage of a significant lung burden.
Yeah, I'd agree, and I think that we can't just use the screening tools that we use for chronic silicosis in this setting. So the Safe Work Australia questionnaire. Reliance on ILO reported chest X-rays is not appropriate for this. We have to start somewhere, and that's where we've started. But I think we've put a lot of thought and effort into modifying those tools to this type of exposure. So. And there'll be a lot of people that are missed early on, and there's going to be a need for a lot of education of general practitioners as well to sort of look at taking occupational histories and having them involved in potentially case detection as well.
Ryan, it's Rob McDonald.
Oh, hang on, sorry, we've got a couple more in the room here, so we might just keep moving.
MRI, it hasn't been validated yet, or doesn't it pick up this silicosis?
So yeah, MRI, no. So we can't really use MRI for the lungs because of the it needs a water interface. So you've got too much air in the lungs. So we're always a bit stuck with MRI. So there is a little bit of data around PET scans to differentiate more active disease, and also looking at low dose CT scanning, because low dose CT scanning has really come a long way in terms of how high resolution it can be, and the new forms of low dose CT, some of them actually have less radiation than a chest X-ray does. So so it's a really quite rapidly evolving technology. David?
Just on the preventive angle, you've clearly demonstrated that wet cutting techniques alone aren't going to get our levels down sufficiently. So what's the current advice on, I have to work in the stone, artificial stone benchtop industry, or I'm running a business there, what should I be doing? Apart from shut the business, what would your advice be? So
to the employer? Yeah, so to the employer, I've heard of wide-ranging practices, and it does tend to be the big companies, and there are some really big companies that do this, those that employ 20, 30, 40 stonemasons, and they many of them have invested in multi-million-dollar equipment, cutting equipment. So, but even in that setting, you need to have objective monitoring of dust levels. And until that's done, I don't think you can demonstrate that your levels are actually at an appropriately low amount to say that there's a safe work environment. But David, I haven't seen that that's actually been done. I think a lot of companies have invested in this type of equipment, but not actually proven how effective that they actually are. Andre, do you want to make a comment about that? Because you've been to a few of these workplaces, haven't you?
No, I haven't actually. Most of them haven't let me into their workplaces.
Right.
I have been able to see some of the workers, and we've done quite a bit of health surveillance so far for Silica at Sonic. Not one of the ones that we've seen, I reckon we've seen 50 or 60 workers so far, have had any form of occupational hygiene monitoring done. Not one of them. And a lot of dry cutting has been, and we've had upwards of 15 cases so far, probably more, with abnormalities on their chest X-rays alone. Some of them will be early cases which have been missed because all that's being done is spirometry and chest X-ray. We're being referred to get HRCT, but they're not all being done. Some workers are so worried about losing their jobs. Some of them from overseas are very worried about losing their visas. Quite a lot of them are on 457 visas. A lot of them want to try and get permanent residency in the country. They're terrified if they put in a workers' comp claim or anything else, they'll lose the opportunity. They'll be sent back home. So it's a pretty difficult situation out there for a lot of them.
Yeah. Yeah, no, absolutely. Like, there's so much complexity to it. So, yeah, we've been pleased that WorkSafe over the last few months have been putting quite a lot of time and energy into this issue, and so we're hoping for a positive announcement about the extent of a screening program very shortly, so stay tuned as to what that might be. So, in my opinion, it's long overdue. So, and unfortunately, there's been a huge amount of harm done to so many people that work in this industry that we're going to be seeing for decades to come. So, but as I say, this is not just an Australian problem. I've spoken to colleagues in China, colleagues in North America, where they're starting to see cases. But I think we've got an opportunity at the moment to really lead the way with this, to be leaders in terms of occupational health, and to gather as much information as we can to help those other countries as well in terms of how to actually address this problem. So I think certainly from a occupational health point of view, time's of the essence as well for these workers, and getting those that need to get out of the industry as quickly as possible, and then supporting them to look at retraining or getting into another industry, because they're all, a lot of them are very well, they actually have normal lung function. I've got I saw a guy the other day still playing footy and, playing basketball, no respiratory symptoms, but has silicosis. They need to be supported and get on with their lives and do other things, so that the psychological aspects of it don't become overwhelming, because that is a huge problem for a lot of these people in the industry. I've seen a few that have had marriage breakdowns. So that's a really big part that needs to be properly addressed as well.
How do you establish?
Yep, go ahead.
How do you establish prognosis and the likelihood of, or the risk of, rapid progression?
Yeah, so in my mind, it's a few things. So one is the exposure history. So as to how long they've worked in the industry, how long they've been in an environment where there's been dry processing, and when that occurred. So if they've only just recently got out of the industry and they had, say, 7 years working in a dusty environment, that's going to be very different to somebody that got out of the industry 5 years ago. But also their current CT findings. So if they've got just small nodules, have they got evidence of PMF? A lot of it's just following them up over time. So I saw one just recently I'd seen back in 2016, and he got out of the industry at that time, and I thought, well, actually, there's probably a low chance of him progressing based on his exposure history, but he's actually progressed quite significantly radiologically. So they all need a clear plan as to follow up under a specialist as well. And again, that's something we're working on at the moment, as to how frequently they should have lung function, how frequently they should have follow-up CTs, at what point do we do a biopsy, at what point do we refer them to the Alfred for consideration of transplant. So I think I've got about 4 or so that I'll probably be referring pretty shortly when they come back for follow-up scans. And then there is a lot of research at the moment about, or plans for research about looking at new fibrotic agents, anti-fibrotic agents, I should say, that we use for idiopathic pulmonary fibrosis. Is there a role for those agents in this disease? So there's quite a lot of research that needs to go in terms of the disease mechanisms as well. So if you know anybody with money that wants to fund research, just let me know. Bruce?
Interested about the autoimmune connection. You mentioned about rheumatoid arthritis, scleroderma and so forth. How much do you need to have silicosis to develop those conditions? Because there is some suggestion exposure to silica, but not necessarily silicosis, can lead to those conditions, Erasmus syndrome and Kaplan syndrome and so forth, or at least Erasmus syndrome. Is it that in the older papers which identify this connection, they didn't have HRCT and didn't recognise silicosis was there, and just thought a plain X-ray showed it there wasn't silicosis, and therefore the exposure to silica per se led to the autoimmune disease? Or is it necessary that there is that intervening step of silicosis before the autoimmune disease?
Yeah, I think you're absolutely right that I must say I haven't gone back and looked at those papers, but you're right that there's certainly an association of autoimmune disease independent of silicosis, so just related to the exposure. So, but you may well be right that it was based on chest X-ray, not CT. So, one of mine that I think of in particular has got, really terrible scleroderma, and he's got very mild silicosis based on his CT. I had to actually get that read by a couple of radiologists before they actually did say that there was signs of small nodules. So, and unfortunately, he'd been seen by a rheumatologist for about 3 years who didn't make the connection. So he kept telling the rheumatologist, I work in this industry and I'm quite concerned about it. And the rheumatologist kept sort of saying, no, there's no issues there. So, it's certainly something that needs to be made more aware of in that community as well.
Connections is, you mentioned about the nascent silica fragments stimulating a reactive oxygen species, and the question of whether that necessarily leads to fibrosis in the lung or whether it can influence a immune reaction elsewhere in the body.
Yeah, no, I think absolutely. And the other issue is that is the particle size. So because they use such high intensity power tools and being done through dry processing, you're actually getting nano-sized particles that are produced as well. And so they can pass through the alveoli and can have systemic effects. So, that may be a factor as well.
Ryan, are you
Rob,
seeing any?
Rob, when you get a chance, I'd like to ask a question, but go ahead there in the room.
Yeah, are you seeing any higher rates of these the rheumatoids and so on with these types of silicosis, or is it about the same as it is with the old chronic ones?
I think so. So I think probably about a third would have autoimmune disease as well. So something I mentioned before, I had somebody with quite a bad skin rash that came back to see me, and I sent them to a dermatologist and found they had cutaneous lupus. So I do autoimmune screens on everybody, and I'd say about a third are positive. And that's certainly, I think, a significant risk that if they don't have autoimmune disease now, they'll likely go on and develop it down the track. And that was quite similar to the numbers that they've seen in Israel, where they've done autoimmune screening on most of theirs as well. There's a question online.
Yeah, Ryan, it's Rob McDonald. Thanks for the presentation. It's been very, very informative. Look, I've got a couple of questions. The first one, I think you referred to the initial screening of chest x-rays, only 50% of those were normal, and then high-resolution CT scans showed they were abnormal. So I guess the question relates to was, first of all, were those x-rays actually read by ILO B-trained readers? Because there could be a sensitivity issue there.
So the answer to that question before you go on, yes, they were. So they were all in Queensland, and as you know, Queensland's got a much better radiology base with B readers up there. So they were all qualified. Right.
Okay. So yes, I think you probably said so. It's really a different disease different disease process, and so chest X-ray screening isn't sufficiently sensitive. Because what we're seeing as you're aware, in cold workers pneumoconiosis with a chronic disease, it's almost the opposite. For every 2 to 3 plain X-rays that are read as being CWP ILO1, high-resolution CT scan is then ruling them out.
Yeah, it's interesting, isn't it? Yeah, so it really reflects the major difference in the exposure that we're dealing with here. And I think one of the reasons why we haven't just automatically said everybody needs an HRCT is that there is, we do pick up a lot of incidental lung nodules when we do that. So, my general respiratory practice, I get lots of referrals for incidental lung nodules. So if you go and if we do an HRCT on everybody in this room, we'll probably pick up about 5 or 6 of you having lung nodules. So what's the meaning of that in this situation when somebody's had exposure? So that's one of the reasons why we haven't said automatically everybody should have an HRCT, but it should be based on that exposure history. But again, having a very low threshold for the CT rather than just the chest X-ray.
And look, my next question just is going to be a little bit more provocative. So, clearly, we occupational physicians at the Thoracic Society have got a really important role to play moving forward. But I guess, hindsight's always, 20/20 vision and hindsight. This disease was entirely foreseeable. So, what are your thoughts on the role for the College of Occupational Physicians and also the Thoracic Society to actually be more proactive in terms of these emerging issues. And I mean, I feel that we've failed workers in Australia because this was foreseeable, and what's our role to be more proactive, to be much sooner in responding to these sorts of issues, not waiting for cases to occur, but actually to be, predicting that these are going to occur and being more active with regulators to make them see the risks that are out there.
Yeah, so I think I've actually been really very heartened by the level of advocacy and concern amongst the respiratory and occupational physicians about this problem for the last few years. So certainly when it came onto our radar in 2016, so certainly AFOEM have done a huge amount of work in this area over the last couple of years. Certainly Graham Edwards in Queensland's been extremely I'm not sure what the right word is, but he's been pushing a lot. He's been pushing a lot. So I think I think we've done what we have been able to do, but I think a lot of this comes back to the government's response, and and also the argument which we've pushed for quite a long time about having a proper occupational lung disease registry, where if we had had a system to notify the registry when the first case happened, then there would have been a requirement for a proper investigation, that sentinel health event, to actually investigate why it happened, to look at the industry more broadly. So a really open forum like a registry to actually be able to identify these emerging problems. So I think that would have helped a lot, but we're getting no traction still about a registry throughout the country at the moment. So I think there will be sort of limited registries, probably more specifically related to silica and some pneumoconioses, but not really covering all the other important occupational lung diseases as well, like occupational asthma and various other things that do go by the wayside, unfortunately.
Thank you.
That education of workers, I mean, when they apply for these positions, and I suppose when they do successful in obtaining these positions as in the construction and manufacture of these artificial bench tops. Are they the education and training for workers? Because I think that's really important, that they're exposed to the dust, but they probably don't really understand the risks, the high risks.
Yeah, so in terms of training, I think it's been terrible. Like I've been shocked that I've had quite a few that have gone through the stonemasonry course at Holmes Glen, and no education whatsoever about silica dust exposures. So that's a major. We haven't got around to that aspect yet. We've been trying to sort of push for government action. So, but that's definitely part of it as well. And so we're hoping that at some point, especially when the extent of this comes to light, that there will be a really thorough review as to how it's actually happened. So, but so we're still. Yeah, definitely the trade schools and looking into issues of education there.
Once you've diagnosed a worker with silicosis, do you advise him to leave the industry?
Yes. So like I must say, early on, I was sort of wavering a little bit with some of them. I think I would spend a bit of time thinking about it. Can we look at doing other tasks? One was going to do on-site installation work, some measuring. Maybe work in the office, that sort of modification. But really, when somebody's in their early 30s and they've got silicosis, they need to get out of the industry as soon as possible and just start anew somewhere else. Andrea?
Yeah, I'll just make a comment about that. The ones that we've seen, a lot of the guys don't want to leave their workplaces because the WorkSafe inspectors are saying it's all right for them to be wet grinding and doing other tasks, and employers have been reassured that they're fine.
So we're hoping that's going to come to an end very soon. So again, The inspectors, get me started on the problems there. But yeah, so yeah, there's been problems in terms of the advice from the inspectors. Bruce?
But if people do leave the industry, does the progression of disease slow, or is it just with this new sort of silicosis we're talking about, is it just on tram lines it's going to progress?
It's likely to slow. It's likely to slow. Just reducing that overall burden of exposure, that cumulative dose, similar to the way we think about, cigarette smoke exposure. But the problem is that the silica is actually, a lot of it's retained in the lungs, and it's actually the clearance mechanism that actually induces silicosis. So if you therefore have less silica going into the lungs, then, it is going to lessen the progression. But we don't know, that's the short answer. There's a lot we don't know.
So those X-rays you showed us a progression from baseline through to 36 months. Was that of a person who'd left the industry?
Who'd left the industry, yeah. I've got a few others that are exactly the same. And the experience in Turkey with the sandblasters there was exactly the same as this. So they all had significant progression.
What's the life expectancy of the transplants?
So it's improving all the time, but currently the average life expectancy post-transplant is 10 years. So it's not like getting a whole lifetime ahead of you. There's quite a high early mortality, so over the first 30 days. But then if you get through that period, then there's issues with rejection and other problems. But about 10 years. There is a role for transplanting again. You can have a second transplant, but it gets more and more complicated as time goes on.
I'm going to ask another question. Sorry, I sound like the eternal questioner here. If the patients don't feel they can afford private cover, don't want to lodge a workers' comps claim, which we are seeing a little bit of this around, which of the public hospital thoracic units do you think would be the most suitable, maybe, that we could encourage them to go to? Because I think they'd be seen fairly quickly.
Yeah. And so, I've harped on about this as well to my respiratory colleagues too. So they're all pretty well informed, and most of them now have had experience, with workers. But definitely at the Austin, I'd say the Austin and the Alfred. The Alfred runs a multidisciplinary interstitial lung disease clinic there, a lot of clinical trials. And the Austin have one that's almost at the same level as that. So those would probably be my two go-to departments.
The Austin would be quite good because there's a lot of industry out in those suburbs that do this sort of work.
So Nicole Go's the respiratory physician that heads that service out there. GOH.
Right.
Yeah.
I just wonder whether this isn't perhaps part of something that worries us all, these sort of whole nanoparticles things, because we sort of read about nanoparticles in sunscreen, nanoparticles in this, that and the other thing, and the answer at the moment is really nobody knows. But could this be a manifestation of that as much as anything?
Yeah, it may well be. And so we've got quite a few research proposals at the moment, and so looking at dust size. There's a group in Tasmania that's just got some funding to do that, and looking at particle size and the difference in fibrogenicity of the nanoparticles versus bigger particles. So, and we've got a couple of NHMRC proposals in at the moment for more research funding. So, hopefully we can answer some of those questions.
We'll have one more question and then we might sort of wrap it up. Any more questions?
Good timing then.
Thank you very much for Mr. Small Token. Thank you so much. Thanks so much, Ryan. That was excellent, really informative, and really important that we're all aware of this emerging, concerning issue. So thank you again. So just before we finish, David Eaton mentioned that there's some vacancies on the medical panel, and there's some leaflets and handouts that people can take if they are interested in the medical panel work. So, did you want to say something, David? Or? That's a pleasure.
Just very quickly, the next round of the 3-year appointments, the applications are opened this week and they finish at the end of the month. So if any of you think you may be interested in doing some work with medical panels, I've left some leaflets at the back. It's got an email address there. If you're interested, drop us a line. Someone will get back to you and help you with the application process. But we desperately do need some more occupational and environmental physicians to help us with the work that we do. Thank you. Thanks, Robin.